So yes, my research was over the clinical need for educating nurses about diet modification for individuals with dysphagia. But before we begin, there's some background information that I'd like to discuss. So let's begin with the swallow. There are 3 stages of swallowing: the oral stage, the pharyngeal stage, and the esophageal stage. The oral stage takes place in the oral cavity. It's where chewing takes place and the bolus is formed. And the bolus is just chewed up food or liquid that is formed through chewing and the mixture of saliva. And here would be the pharynx. So this is the pharyngeal stage. It would be the transfer of the bolus through the pharynx, and the esophageal stage is the transfer of the bolus through the esophagus to the stomach. And there's the esophagus. And as we can see, the different stages: the oral stage, pushed to the back of the mouth through the pharyngeal stage, and the esophageal stage. When there's a problem with any of these stages, it is called dysphagia. And there are some risks with dysphagia, which include malnutrition, dehydration, choking, aspiration, and pneumonia. And aspiration is when food or liquids enters the airway and gets into the lungs, and that can lead to pneumonia or even death. Dysphagia is relevant and a prevalent problem that is encountered in the work setting of both nurses and SLPs. And dysphagia is prevalent in 68% of elderly patients admitted into nursing facilities. There are 2 types of treatments of dysphagia in dysphagia management, and these include rehabilitative and compensatory treatments. And rehabilitative treatments are designed to restore function and strengthen the muscles in the oral stage and the pharyngeal stage. So there's different exercises you can do to strengthen those muscles. And compensatory treatments are designed to alter the swallow and redirect the bolus. So these include postures, maneuvers, modified mealtime environment, and diet modification. This study specifically looks at diet modification. So a little bit about diet modification. When we modify the diets, we modify the consistencies of the food, either solids or liquids. For solids, starting with most upgraded and ending with most downgraded, we have regular, mechanical, soft, and pureed. And when we downgrade solids, we are making them essentially softer and involving less chewing. And for liquids, starting from most upgraded and ending with most downgraded, we have thin, nectar thick, honey thick, and pudding thick. For an example of thin would be water. Example of nectar thick would be like syrup, and then honey and pudding for the other 2. And downgrading and upgrading are complex decisions, and when we downgrade a diet, it can be safer for some patients, but that is not always the case. So specifically looking at the liquids, when we thicken the liquids or when we downgrade them, although a patient's diet is modified to prevent the risk of dysphagia, there are still potential risks when downgrading, and is not always the safest option. A potential risk when downgrading liquids is it may lead to aspiration, and for some patients, aspirating thickened liquids can increase the risk of pneumonia as a result of the increased difficulty to clear the airway to clear the liquid from the airway. So the roles of speech-language pathologists, or SLP, in dysphagia management. SLPs play an important role in dysphagia management. They modify diets as part of their regular treatments, and they also conduct clinical evaluations of the swallow mechanism to assess function and identify disorder. SLPs also make diet modification recommendations. And now, nurses' role in dysphagia management, they also play an important role in dysphagia management. They are the ones who are closest in contact with the patient, and they monitor the patient's diet and any ensuing problems. They also, and although CNAs may have knowledge of routine aspects of feeding, they may lack familiarity with feeding techniques for residents with dysphagia and how to react or recognize those signs of dysphagia. And oftentimes, Nurses often believe that downgrading is safer, and they will downgrade without an SLP consult if it is needed. However, as we discussed in the previous slide, downgrading isn't always the safest option for some patients. So my study aimed to answer 3 questions, which is what is the education and training for nurses, or in the area of dysphagia for nurses who work with dysphagia? The second one is, are nurses willing to downgrade without an SLP consult? And the last one is, did the short general SLP-led dysphagia in service change nurses' views about changing diets without SLP consult? So the materials we used, we did a survey, and we sent the survey through Qualtrics, and we sent the survey out through email. And this email, the recruitment was through the nursing school in Fort Wayne and through Indiana State Nursing Associations. And in the email, we explicitly explained that it was completely voluntary and anonymous. So our research design, it was a pre and post test survey, which was divided by a 2-minute video tutorial of a slide presentation with voiceover. The tutorial focused on diet modification and for dysphagia management. And for the independent variable, we had that short video in service on why downgrading is not always safer for liquids. And the dependent variable was nurses' willingness to consult SLPs. In the pre-test, we had the demographics information was collected, which was at the beginning of the survey, and this included the age, the years of experience, for the employment setting for practicing nurses, years in school for students, and prior education related to dysphagia. In the pre-test and post-test, we asked the nurses specifically if they were willing to upgrade without an SLP consult and if they were willing to downgrade without an SLP consult. We also had 2 scenarios involving diet modification decisions, and the scenarios in the post-test were not the same. They were similar, though, to the pre-test scenarios. That way we could assess the efficacy of the video in service in educating the nurses. Our participants, we had 34 practicing nurses, and we had 7 nursing students who were also practicing, and so our total was 41 participants. Now to discuss the results, we found that 40% of the participants were between the ages of 55 and 64. This chart shows all the participants. So this is the years of experience that they reported, and it shows that all participants have more than 1 year of experience, and over half had, or about half, had more than 31 years of experience. Here we kind of see a wide range of settings. Most of them, about half of them, said other. So for their current setting, they selected other, and they had an option to state what that was. There was a box for it, but most of them didn't, so we're not exactly sure. And the next closest was about 21% with acute and subacute settings, hospital settings. The primary population caseload for the participants, about 54% of the participants worked with adults, and participants work with dysphagia population. We discovered that 69% work with dysphagia or have worked with dysphagia population in the past. Their training related to dysphagia in the past 12 months. So 13% reported having education or training on dysphagia in the past year. And this is formal education or training regarding dysphagia in the past. And about 54% reported having formal education or training regarding dysphagia. The pre and post test and in-service results, we have, this is regarding the video that they watched in between the 2 tests. And the participants, there was 29 out of the 37 who reported watching the video in its entirety, and 5 said that they completely skipped it. So this is to answer the question, can nurses upgrade without an SLP consult and can nurses downgrade? The 3 on the left here are the question, can they downgrade without an SLP consult? And the 3 on your right would be, can they upgrade without an SLP consult? And the blue is the pre-test responses and the orange is the post-test, so we can see the comparison of the results before and after the video they watched. And we can see that fewer participants are willing to upgrade than they are to downgrade. And both upgrading and downgrading responses without an SLP consult went up post-test. It went up about, so about half of them said they could, or over half said that they could downgrade without an SLP consult, and that jumped 3.05% post-test. And over 15% said that they were willing to upgrade without an SLP consult, and that jumped post-test 3.54%. This is the same question. However, we just took out the participants that skipped the video, and we can see that those willing to downgrade, there were still more willing to downgrade than they were to upgrade. And we can see in both of these, when the ones willing to downgrade pre-test went up post-test. However, with upgrading actually went down by 4.76%. So nurses, this is just those who reported having formal training on dysphagia. And those willing to downgrade without an SLP consult increase, or it actually went down this time, and it went down by almost 5%. And those willing to upgrade actually stayed the same pre and post test. And we can see that they were less likely to say that they were unsure if they would downgrade or upgrade compared to all. And then also compared to this next one is those who have not had formal training on dysphagia. So we can see a huge percent, about a third of them were unsure whether that they could upgrade or downgrade without an SLP consult, as opposed to those who have had training, they were less likely to say unsure. So this is a comparison across all 4 of them, just looking at all of the participants, those who watched the video, the formal training, and no formal training. And we can see that the participants were less likely to upgrade without an SLP consult across all of them. And in all cases, the percentage of participants who were willing to downgrade and upgrade without an SLP consult increased post-test. However, for formal training, the upgrading actually just stayed the same. So to discuss these, to answer the first research question, which was what is education and training in the area of dysphagia for nurses who work with dysphagia? And we found that there was no way to determine what the education was regarding dysphagia for the nurses that work with the target population was, and that about half of them believed that they were formally educated in the topic in the past. So their education seemed to have supported their decision in not upgrading without an SLP consult, as we saw fewer were likely to upgrade without an SLP. But it did not protect them from the decision to downgrade without an SLP consult. Research question 2, to answer this, which is, are nurses willing to downgrade without an SLP consult? The answer is yes. Nurses appear to be willing to downgrade without an SLP consult. In every case, subjects were far more willing to downgrade than they were to upgrade without an SLP consult. However, it was still concerning how many were willing to upgrade. The results show a need to provide better interprofessional education to nurses regarding diet modification and risks involved in both upgrading and downgrading diet consistencies. And the last research question, which was, did the general short SLP-led in-service change nurses' view about consulting an SLP without or change nurses' view about changing the diet without consulting an SLP. And we discovered the answer was no. There was no benefit to this type of general tutorial. And the short video seemed to have confused subjects more than it helped with respects to understanding the risks of downgrading diets without an SLP consult. And there was no effect of formal training on these results. And across those who watched the video and those who didn't, the results suggest that watching the video had the same benefit as not watching it at all because they had similar results. So there were some limitations to this study, which included the number of participants. There was a small number, and they all resided in Indiana. Also, Qualtrics embedding to the video may have been, it wasn't optimal, so it might have been the reason why so many participants skipped it. We asked about prior training, but there was no way to standardize the contents of the training that they reported having. And lastly, we tried to avoid a bias by telling them it was led by the videos and survey was coming from SLPs. So it might have been obvious though, so that might have also been another limitation. So to conclude, although the short general video tutorial was not found to be useful in educating nurses regarding diet modification decisions or communicating to them the risks associated with downgrading and upgrading, the findings support the clear need for education regarding diet modification, the risks associated with downgrading. And there are some recommendations that education regarding dysphagia be implemented at the curricular level before they start practicing. That way they have this education going into nursing. Also, interprofessional collaboration and in-servicing in the field be tied to specific cases and patients, which may result in better efficacy for short-term training. And that's all.
All right, it's open for questions. If you guys have any questions, just please wait for the mic. Thank you, Sydney. My question is, and I'm sorry if you have mentioned it and I just missed it, but since the nurses found that downgrading is safer, downgrading the diets are safer, but the importance of the videos or the tutorials or the training from the speech language pathologist, is that correct?
Right.
Is not as useful. So what should be done then for the nurses not to just go to the downgrading the diet?
Right. So to educate them on this and try to prevent them from downgrading and upgrading without an SLP consult, we would like to have an in-person in-service instead of just a short general tutorial that's unilateral. If it's in person, that way they're able to ask questions and understand things that might be confusing. And also to do it alongside nurses, so collaborate with nurses and have this in-service where they're both training the nurses that way. It's not just like an SLP telling them what to do. They have a nurse who's in their field who's also saying, hey, this might not be the safest option. So we think that interprofessional collaboration and in-servicing interprofessionally in person would probably be the best option. Did that answer your question?
Yes.
Okay.
I have a follow-up to that last.
Very nice project overall. Excuse my voice. With having only 41, I wonder, when you see percentages changes of 4 or 5%, is there any way to do a statistical analysis to say whether that percentage is significant or not? I'm just wondering. I'm not an expert in that, and I don't know if that's possible or not. But I'm just curious because you're drawing some conclusions from those percentages.
Right. Yeah, that's a really good question. I'm not exactly sure. I think 41 is actually a pretty significant number compared to some, it's bigger than a pilot study. So that shows some significance there. This study was also conducted previously at another school with my professor and a different student, and they had a much smaller range, but it showed similar results across both studies. So yeah, I would definitely think that if this study would be conducted again, it would be nicer to have a larger percentage of nurses or number of nurses and participants who were involved in it. But yeah, that's all I can answer so far, but thank you.
Hi, thank you for your presentation. This is probably a very basic question, but I'm wondering, what is it in the training of a speech-language pathologist that gives them more expertise in the subject than nurses would have?
That's a good question. Yes, SLPs study the muscles involved in speaking, which are also involved in swallowing. And so they have a they have an understanding of the anatomy, as well as they can specialize in swallowing disorders. So when they're in grad school, they have that training and that education, and are specifically specifically learn all of the swallowing disorders and are able to make those recommendations. And I would say that nurses also learn about dysphagia, but as we learned from our participants, only half of them had that training. So that could be from college, like from school, or it could be from in-services. We had no way of standardizing that content from the survey that we had, but they learn a more broad range of different, like the whole body. And so SLPs specifically just are specified in the head and neck area.
Thank you very much.
Thank you.